In this first endocrine lecture, what we're going to do is explore the anterior pituitary. I want to start off by going through a little bit of the anatomy and physiology of the hypothalamic pituitary axis, something that's going to be useful in basically all the lectures that follow, and then go over some of the hypersecreting tumors, prolactinoma and acromegaly, and close out with hypopituitarism. Let's start off by talking about some anatomy and physiology. So you've got the anterior pituitary and the posterior pituitary. But the posterior pituitary is actually a continuation of the hypothalamus. And hypothalamic neurons have their neurons that go into the posterior pituitary and secrete ADH and oxytocin. Now we're going to have a whole lecture on the posterior pituitary that follows this, so I'm going to stay focused on the anterior pituitary. The hypothalamus secretes some hormone through the blood that influences the anterior pituitary to secrete yet another hormone. This is the basis for the hypothalamic pituitary axis. So the hypothalamus secretes something that tells the anterior pituitary to secrete something that goes to a target organ and tells that target organ to secrete something else. And that hormone that it secretes has a final metabolic effect. And in descending order of importance, that is the thing that keeps you alive to the thing that doesn't really matter, from the anterior pituitary is ACTH, TSH, GH, and then FSH and LH. We'll get to this in a minute, but ACTH causes secretion of cortisol. You need cortisol to maintain your blood pressure. That keeps you alive right now. TSH secretes thyroid hormone from the thyroid. That keeps you metabolically active and keeps you engaged, keeps you alive days to weeks. Growth and reproduction really don't matter if you can't function or can't maintain your blood pressure. So let's talk about each one of these individually, and then we'll talk about the feedback loop. The hypothalamus secretes CRH to stimulate the anterior pituitary to secrete ACTH, which goes to the adrenal glands to secrete cortisol, which allows us to respond to stress. It increases the blood glucose and lets our vasopressors, or endogenous blood vessels, work. In regards to the thyroid, TRH is secreted from the hypothalamus, which tells the anterior pituitary to make TSH, which goes to the thyroid to secrete T4, which gives metabolic activity. It's basically the spark plug for all of the organs in the body. You need T4 to live. Growth hormone releasing hormone causes growth hormone to be released, which targets the liver to make insulin-like growth factor 1, which causes things to grow. Things that can grow will grow. And then gonadotropin releasing hormone causes gonadotropins to be released from the anterior pituitary, which goes to the reproductive organs to secrete testosterone and estrogen, which then lead to reproduction. But this is set up in sort of a feedback mechanism, such that the distal hormones feed back on the proximal ones. So testosterone and estrogen, for example, would feed back and inhibit FSH and LH, as it would inhibit GnRH. And FSH and LH, so too, feed back on GnRH to inhibit it as well. The idea being, the original hormones get produced. That's the default, it's on. And if you have too much distal hormone, it turns off production. If you don't have enough, it disinhibits. That signal goes to go on. This will become useful as we discuss each of the disorders throughout these lectures. Now that we've got a little bit of the anatomy and physiology taken care of, let's talk about two hyperfunctioning tumors. Let's start off with prolactinoma. And as the name suggests, it is going to be a prolactin secreting tumor. It is not a cancer. It is benign. And prolactinomas will present in one of two ways. And it's different for women than it is for men. Women tend to notice amenorrhea and galactorrhea. So, having noticed amenorrhea and galactorrhea, the women usually come reporting the symptoms sooner than men do, and so the tumors don't get that big. And so they generally present with microadenomas. The reason why that is important is because the pituitary is in the optic chiasm. If tumors get big, it compresses on the optic chiasm and you get field cuts. But because women notice amenorrhea and galactorrhea, they present with microadenomas, so generally there are no field cuts. In men, though, they don't have breasts that produce milk, and they don't have periods every month, so they can't notice amenorrhea and galactorrhea in themselves. So generally, the symptoms are going to be something like a decreased libido. You might be distracted for some other disorders. But over time, the tumor is going to grow, and you'll get macroadenomas. And because these macroadenomas are now big, the prolactin tumor compresses the optic chiasm, you get bitemporal hemianopsia, positive field cuts. They can't see peripheral vision. The diagnosis is a little tricky. You might think, oh, prolactinoma, I'm going to get a prolactin level. You're right, but there's some stuff you have to do first. You start the diagnostic workup by looking at medications, because if they're on a medication that can produce a small elevation in the prolactin level, change the medication. Then you want to check a TSH, because hypothyroidism can induce hyperprolactinemia. And only if these are not the culprits do you check a prolactin level, confirming elevations in prolactin in the blood. And if you have elevations in prolactin in the blood and it's not medication or TSH induced, you'll need the MRI to look for the tumor. The treatment for prolactinomas is going to be with dopamine agonists. And carbergoline is better than bromocriptine only because of the side effect profile and dosing. You can really use either one. And very rarely will you have to use surgery or radiation. This is only in the case where the tumor fails to respond to medical therapy, which is rare. Let's look at this again in a diagram to really get a strong hold on it. What we think is happening is that the anterior pituitary is producing prolactin. So we have an increase in prolactin levels that are producing symptoms. But other things can cause it. Normally, dopamine inhibits prolactin secretion. When you get put on a dopamine antagonist, such as an antipsychotic, you disinhibit prolactin. So dopamine's red, normally inhibits prolactin, but those dopamine antagonists are green, so induce prolactin elevations. This is a reason for noncompliance. People do not want gynecomastia, galactorrhea, or amenorrhea, so they take themselves off these medications. The other way you can increase the prolactin level is by having very high levels of TRH. Now we learned already there's a feedback loop such that if you lose T4, you lose the feedback inhibition, so TRH will elevate in the case of hypothyroidism. Which is why we start off with the more common, cheaper tests. We rule out the medication list, we get a TSH, and if the TSH is elevated, then we know there's hypothyroidism, and pay attention The TRH causes the prolactin elevation, but the TSH is the test we measure. If there is hypothyroidism, we treat with levothyroxine and give them the T4 back. But if the TSH is normal, then we want to make sure indeed we have elevations in the prolactin. Because if there is normal levels of prolactin, it is not a prolactinemia, so it can't be a prolactinoma, it's something else. But, for this testing, prolactinemia will be present, the prolactin will be elevated, and you get an MRI. Now, if the MRI is negative, it's something else outside our scope, but for our purposes, it's going to be positive. Then you have a prolactinoma, which you're going to treat with dopamine agonists. And only if the dopamine agonists fail do you do surgery and radiation. That's prolactinoma. Let's talk about acromegaly, and then we're done with the hyper-secreting tumors. Acromegaly, very much like prolactinoma, is a benign tumor, growth hormone secreting tumor. And while acromegaly itself is non-cancerous, growth hormone causes everything that can grow to grow, and so that includes cancer cells. So these patients are at increased risk for developing other cancers. The patient presentation is going to be different for kids as it is for adults. Growth hormone causes everything that can grow to grow. If you are a kid, before the closure of the growth plates, growth hormone is going to cause the long bones to grow and you get gigantism. Really tall because you have really long bones. But in adults, after fusion of the growth plates, only the things that can grow will, which is going to be the hands, feet, face, and visceral organs. And it just so happens that growth hormone stimulates glucose production, so you'll get diabetes. The things that kill these people are visceral organ growth, leading to diastolic heart failure. That is, you get left ventricular hypertrophy so bad, the heart cannot relax to accept any blood. It's going to be hard to spot these people, because diastolic heart failure and diabetes happen in a large percentage of our population. So what you're going to look for are the hands that rings don't fit on anymore, or hats need to be resized. Or if you look at a picture from someone from 10 years ago to now, there's a stark contrast. The space and the teeth have gotten worse. Their face is more coarse and a lot bigger. The patient won't notice because it is not an acute change, but it will be obvious if you look back in time. Acromegaly is a little tricky to diagnose too, because you think, it's a growth hormone secreting tumor, I'm going to check a growth hormone level. Wrong. You're going to start with an insulin-like growth factor 1. And if that's elevated, you'll do a glucose suppression test. And only if the glucose suppression test is positive will you confirm the diagnosis with an MRI. And very unlike prolactinoma, the only treatment for acromegaly is surgery. Though if you have any residual tissue still doing any damage, you can use octreotide. Octreotide is somatostatin. Insulin-like growth factor 1 is somatomedin. Octreotide turns insulin-like growth factor into stasis, suppressing the growth. Let's look at this in pictographic form. Growth hormone is going to tell the liver to do two things. First, make glucose. That's how you get the diabetes. It also tells the liver to make insulin-like growth factor 1, which stimulates bones and the visceral organs to grow, which is how you get wide-spaced teeth, coarse features, big face, big hands, and diastolic heart failure. And we can use this then to work up a diagnostic tree. You think that there's an elevation in the growth hormone. You're going to start off with insulin-like growth factor 1. Because if insulin-like growth factor 1 is normal, your screening test is negative, you're done. Then you do the glucose suppression test. Talk about that in just a second. If the glucose suppression test suppresses, it does what it's supposed to do, it's not acromegaly, and you can stop. But if it's positive, that it fails to suppress, you then get the MRI. If the MRI is negative, it's out of scope, don't worry about it. And if the MRI is positive, you've got the tumor, you need to resect. Okay, so then what is a positive glucose suppression test? Normally, blood glucose is regulated by insulin. And insulin competes with all other hormones, epinephrine, cortisol, and growth hormone. So the insulin tries to bring down the blood glucose, all other hormones try to bring it up. So if you give someone an oral glucose load, you give them sugar, what should happen is the insulin should increase to try to bring the blood glucose back to normal. The other hormones should shut off. So epi will go down, cortisol will go down, and a positive test is when growth hormone that should decrease does not change. All right, lot to know. Now, you know already that there are other diseases because we didn't talk about TSH or FSH and LH, right? So in the adrenal section, we're going to talk about hypercortisolism, so Cushing's disease of the anterior pituitary, talked about there. Central hyperthyroidism is extremely rare. Don't even want you to know about it, though be careful because it might come up on the test, where the TSH is elevated as is the T4. That's weird, and it's indicative of central hyperthyroidism. Basically doesn't happen. And the diseases of FSH and LH, body doesn't care about, not going to talk about them. Those diseases do exist, but the one I want you to study are prolactinoma, women amenorrhea galactorrhea, men field cuts. Make the diagnosis first by looking for dopamine antagonists, ruling out hypothyroidism, then confirming the diagnosis with prolactin levels for prolactinemia and MRI for the cancer. Treatment is medicine, not surgery. Versus acromegaly, kids get gigantism, adults get diabetes and diastolic heart failure with this really big, weird, grotesque face change over years. Insulin-like growth factor 1 to screen. The glucose suppression test will fail to suppress growth hormone. MRI is positive, treat with surgery, not medicine. Okay, so that is the hyperfunctioning. Now we're going to change gears and talk about hypofunctioning. Hypopituitarism is going to present in one of two ways. It is either going to be sudden, acute, and devastating, or it is going to be more chronic and insidious. In the acute case, it is generally going to be caused by infection, infarction, or iatrogenic. As in, we did surgery or radiation to remove a tumor and we took too much, or there was just that much to take. In this case, the patient is going to lose all of their hormones all at once, and it will be catastrophic. We talked about in the very beginning that you need cortisol to maintain your blood pressure. Without ACTH, cortisol won't be produced, you get hypotensive. And reflexively, you'll be tachycardic as your heart tries to maintain blood pressure. If you lose TSH, you also lose T4. And T4 gets you to move. So you'll present with lethargy and coma. Now at this point, the body's basically dying, so the inability to grow and reproduce are irrelevant, don't care. Lethargy, coma, hypotensive, and tachycardic could be a sign of loss of the cortisol in the T4. What you're going to do to diagnose it, essentially assess for levels of cortisol in T4. And you're going to treat by replacing those hormones. And you're going to learn more about the assessment of cortisol and T4 in the subsequent lectures. But I just want you to know that if you see this, the person you're giving pressors and fluids, and you can't get them to come out of a coma, and they're hypotensive and tachycardic, they're not getting better. Check a random level and replace as needed. The two things you really should be able to recognize are Sheehan's and apoplexy. Sheehan's is pregnancy, a prolonged delivery, lots of blood, there's an infarct of the pituitary, and right after, coma. Apoplexy is in the setting of a large tumor that you know about, and all of a sudden they become obtunded with nuclear rigidity and a headache. That's apoplexy. Both of these can result in acute panhypopituitarism. But what's more common is going to be the chronic progressive nature of hypopituitarism. And that is going to be caused by some slower working things like autoimmune, deposition disease, or a slow growing tumor that gradually presses on the stalk. Now the patient is going to try to preserve the things that keep them alive. Right, so ACTH we really need, TSH we kind of need, and the things we don't are growth hormone and FSH, LH. So in order to preserve ACTH and TSH, the body is going to sacrifice FSH and GH. It's going to basically divert the resources of the anterior pituitary to get to making TSH and ACTH to keep the patient alive. So the patient is going to present with the symptoms of loss of FSH and GH. So things like decreased libido and some vague complaints like fatigability or problems with FSH and LH, problems with the menstrual cycle. So vague, right? Not something that's very obvious because TSH and ACTH are preserved. What you can do to diagnose it then is take advantage of the fact that the TSH and ACTH will be preserved, so you go after growth hormone. And just as we talked about with the glucose suppression test, you can instead do an insulin stim test. Now, because giving someone insulin and dropping their blood sugar is potentially dangerous, there's also the vasopressin stim test. Which does the same thing. And if these are positive, then you can check an MRI to see what's going on in the brain. So how does this insulin stim test work? Well, we talked about this already. Blood glucose is regulated by insulin. And then counter-regulatory hormones, everything else. Epi, cortisol, growth hormone. If you give someone insulin, the blood glucose will fall. What should happen is that epi and cortisol and growth hormone should increase in order to correct the blood glucose. But a failure to stimulate is a positive test. The treatment is going to be to replace the hormones that are lost and fix the underlying disease. For example, resection of that tumor, treatment of the autoimmune disease, and if you can, reversal of the deposition disease, sarcoid and amyloid. And we're going to close with something that's not a disease. Empty-sella. This is a do no harm point and great fodder for the boards. So normally, when you get an MRI, you have the sella, and the anterior pituitary is sitting right next to the posterior pituitary in the sella. That looks normal. What could happen, normal anatomic variant, you have a sella with nothing in it. People freak out because you still have a posterior pituitary and an anterior pituitary. It's just not where it's supposed to be. So because you still have what you need, there's nothing wrong with the patient is completely asymptomatic. And the diagnosis is going to be made on an MRI you got for something else. Radiologist is looking and saying, hey, you should look at the pituitary. Oh my God, there's no pituitary. So if there's no pituitary, we know what they look like. Dead. So if the person is asymptomatic and the MRI finding shows no pituitary, you know what the answer is. It's empty cell syndrome. You do nothing. And that is anterior pituitary.